Okay, so I'm going to summarize this morning's panel, wonderful panelists, and also we also benefited from the discussions that went before. I think I don't know the order of these points, but one of the first points was the dangers of polarizing healthcare and health research, and that in fact it's a false dichotomy, and we have to be careful that that false dichotomy, which in some sense may permeate regulations right now, as well as some assumptions that are going on in the OHRP draft, may in fact not be to the benefit of patients or for facilitating science. And related to that is this notion that both our ethics and the way we look at this dichotomy between healthcare and health research is 20th century, and we really need to get into the 21st century, both with respect to how research is conducted, how healthcare is conducted, both including insurance limitations and things like that, as well as the fact that participants can be informed in many different ways, including the internet right now. And so we really have to keep pace with what is going on in the world today. Another issue that we addressed, that has been addressed across the different panels, are whether or not and how the risks of SOC research is different from off-study treatments. And I think some of the issues that have come up is that it may not be that the risks are different, but there's a redistribution of risk, and that the risk, therefore, may be different for the individual, although within a group context, that risk have not changed. And the extent to which that creates greater harms or discomforts to an individual participant is still something that I think needs to be addressed and may be of somewhat confusion in draft guidelines unless it is addressed. In addition, I think there was the notion that random assignment in and of itself may not be a greater risk, but it is different. And the extent to which it's different because of preference profiles, rigidity in terms of how protocols are conducted, I think is a question that still needs to be addressed. There seemed to be the notion that when in fact research is being conducted on the extremes of a continuum of standard of care, that in fact that research may not be standard of care, and I thought that was something very interesting that hasn't been brought up before. Clearly, there was a sense of reasonably foreseeable risks. What are they? Are they any different in research than in standard practice? And the extent to which both practitioners, IRBs, and participants can actually understand probability estimates. I thought it was a very interesting discussion about the relationship of minimal risk, and it seemed as if the discussion on the panel was talking about the fact that the notion of minimal risk and standard of care research is, in some sense, a pseudo issue because it was only brought up in terms of issues regarding waiver, and that waiver of informed consent really has to be looked at more carefully, that we're even questioning whether or not waiver is the appropriate term and whether or not we should be talking about alterations in informed consent. So I think that's where sometimes just the wording of the regulations itself gets us into a discussion that appears ethical but is really tied to regulatory language. I think that the next issue really had to do with whether or not there should be informed consent and what should go into the informed consent forms. I think this has come up across the different panels, is that more is not necessarily better. 40 pages is not better. I think others have brought up the notion that there is changes to the common rule that is coming up with respect to abbreviating the informed consent forms, and the question of how OHRP guidance at this moment on standard of care is going to be integrated with those kinds of changes, or whether some guidance may or may not be premature. John had a very interesting 5-point recommendations with respect to what should go into a standard, an informed consent form. And one of the benefits of it is, I think one of the things we had not talked about is that sometimes the research itself may be the patient participant's only introduction to an explanation of what treatment options are. And so I think John's fit nicely into that notion of a researcher who is practicing with care. And so there was your current situation, the disease, the prognosis was number one. Number two were options about the treatments that are out there. Number three was why doctors disagree. And I think that the next was what are the risks and benefits of this type of research. And here I think I wanted to bring in a little bit of what Jerry was talking about yesterday in terms of not all risks, but what are the material risks? How are we going to determine what are the important risks and benefits to the research participant? And that's also something that isn't discussed in the current guidelines about the benefits of participating in research. And some of the benefits that have been discussed is the assessments that are going on may or may not be more detailed, more informative. At the same time, they may, in some sense, result in greater risk if genetic information is being collected. And so there's many kinds of information that needs to go in there. Explaining randomization, but also, I think, as was pointed out, I think, in some of the comments, that it's really important to talk about how, in this kind of research, we're minimizing risk and maximizing benefits. And then the fifth aspect of John's recommendations was whatever you choose, please give us, that you have a choice, number one, and whatever you choose, please give us permission to collect outcome data. And I just wanted to point out that I think in the 1980s, Robert Veitch talked about something called the semi-randomized clinical trial, which was that you ask people to be in a study that's going to be randomized, but you also collect data on the people who said no. And I think a number of people have been, in some sense, recommending that kind of joint design, because it can really tell us a lot about preference and what happens with investigator-oriented care versus practitioner care. So I think it's something we need to come back to. The other types of information that we got from the panel and also from yesterday was the importance of evidence-based informed consent. I think we had wonderful presentations this morning as well as yesterday about research that's going on. It also includes the importance of participant perspectives. And I think, as Louis was talking about, it's very important to understand that informed consent is not something we are doing to, and I think Ed and others pointed this out. We're not doing it to. It's actually a collaboration with a participant, something I've called goodness of fit ethics, when we are kind of fitting our research ethics consent procedures to the characteristics of the participant population. And so the last group of issues that were raised were, can we actually define what standard of care research is in a way that will make guidance helpful? I'm not clear as to whether or not we reached a decision on that on the panel. I think there was a notion that it's important to do so, but may be very difficult because standard of care differs by the population, it differs by the place, it differs by the competencies of the researchers and practitioners who are giving the standard of care. It may differ if one is doing cluster randomization, because it means the hospital may be limited in the types of procedures that it is giving. Whether or not standard of care can be adequately distinguished from other types of research is something that also came up. Issues as to how guidance can be adequately crafted so that it is not a barrier to research that is needed to ensure that we're doing effective interventions, but at the same time protective of participant welfare, and that as OHRP is redrafting its draft, that it's very important to have definitional clarity patient input and participant input, and the kinds of processes that are going to be entailed. And my panel, any added comments? Oh, thank you.
Just one comment. I think our current informed consent technology is actually a 15th century technology, because that's from Gutenberg.
I'm sorry, I don't want to belabor things, but there's both with what you said as well as what Marjorie said about the issue of benefit. I want to come back to because I think that the fundamental issue in the guidance was to say that the purpose of research should be considered a risk. And so you're right. The analogy is if the purpose is a risk, then the benefits there too. I think it's critically important whether these activities and experiences get categorized as benefits and risks versus purposes. And I think for this type of research, my recommendation would be that this ought to be thought of conceptually as the purpose, as the goal. There are goals to look at the benefits and the risks of these interventions. But perhaps for the individual person, there are very few benefits and risks, or minimal benefits and minimal risks of being in the research itself. But what we'll learn from them is more about future patients, and that's compared to their otherwise clinical experience.